I hope everybody can hear me. Give me a just a visual thumbs up if you're on screen. Let me know the volume's okay. Fantastic. So I think many of you were with me 2 weeks ago, but we may have some new folks. So I'm just going to test things out and test your ability to use the chat function. Go ahead and type yes if you were here 2 weeks ago. Type no if you weren't here 2 weeks ago, and let's just see what we get. Okay, I am seeing a mix. I am seeing a mix. So for those of you who typed yes, I'll paraphrase old cowboy movies maybe. I'll say, well, we meet again, but this time I have the action model. And for those of you that are new, I've developed this second workshop as a continuation of the first, but also as a standalone. In other words, it's okay if you missed the first one. This will still work, but some of the topics that I review with your colleagues may be new to you, and that's okay. There's Q&A at the end, but I try to make it so. With that, let me remember to share my slides. That's going to help us a lot. So give me just one sec. That's the one I want. Okay. Fantastic. So as Randall said, I'm Jason from NCSBN. I've been doing a lot of next generation NCLEX presentations these days. It's my job to know a lot about this test, and I'll try to share with you as much as I know, either in the presentation or through the Q&A. So we always start with the small print and the legalese. Translation here, I'm not an attorney, so don't take this as legal advice, but I still say if you see something, share something. You all have colleagues who aren't here who might benefit from this information. Definitely share it freely. You don't just have my permission, you have my request. Small print though, exception at the bottom, there's an email address. If there's anything in this deck that you would want to use commercially to sell, you would need to get permission, and that's that email address at the bottom. Okay, let's jump in. What do I have for you today? Well, we're going to do a quick review of our clinical judgment measurement model. That really is the framework that underpins all the clinical judgment content being added to the NCLEX. So it all starts there. From there, we'll talk a little bit, but I probably give this less attention than I could. We'll talk a little bit about how you would write a successful case study scenario. In other words, provide the information that the case study questions will go with. I'm going to be sharing with you essentially a model scenario that we'll use together today rather than write one ourselves. But then we'll be using a resource called the NCSBN Action Model to create case studies together. We'll do one together, but then I'll talk you through how you can do way more than one using the approach we've taken and some other resources that I'll share. From there, I call it low-tech workarounds. I've had a lot of educators, you're not in the minority, you're in the majority, say to me, Jason, our software doesn't do pull-down menu items or highlighting or some of these things that we've seen from NCSBN. What do we do? Well, that's okay. I'm going to show you things that you can do if you like. I always have NCSBN breaking news and updates. Those of you that were here 2 weeks ago, it might feel like a rerun because nothing's changed in 2 weeks. But for those of you that weren't here 2 weeks ago, you may get some new information there. And we should have plenty of time for questions as well. Now, there are two resources that you may have received by email just a little bit before the workshop. If you don't have them, if you didn't print them, don't worry. Anytime we need this information, I bring it up on screen, so it's okay. I've also seen that nurse educators, when you read about a client situation, it just gets locked in, right? You've got it in your head. You might not even look at your piece of paper ever again. But at any rate, let me introduce the two resources to you. If you did print them out, if you do have them on a second monitor, there's one, it's the vertical one. That is the sample scenario that we will use today. We'll be using it, but I also have it in the slide deck. So again, it's okay if you didn't print it. There's a second resource. I'll call it the horizontal one. This is the NCSBN action model, but I'm going to call it new and improved version. It's what I call our annotated action model. And what does it mean that it's annotated? It means I've added a lot of notes and hints and things like that that help you write the items for your case study. So you'll see that in action. That's really what we're doing here today, is we're using this annotated action model to create case studies. So if you looked at the piece of paper an hour ago and you said, how's this going to help me? Well, we're going to answer that by working through it. So with that, let's jump in. I said we'd start with the clinical judgment measurement model. Something I always do in my presentations is I try to let you know when there is a newsletter that goes with something I'm covering. We've been publishing Next Generation NCLEX newsletters at NCSBN since the fall of 2017. So for quite some time, we got more than 20 of these now. At any rate, the clinical judgment measurement model has a newsletter. I'm going to cover a very small portion of the measurement model. There's more to it. If you want to learn more, extra for experts, the newsletter will definitely have you covered, or you can ask me in the Q&A if you want more. So let's take a quick look at the action model as we talk through its role in the case study. Let me remind myself, yes, I do have that animation. Great. So the clinical judgment measurement model is essentially behind the scenes or under the hood, what we used to figure out how to test clinical judgment. If we think from a testing perspective, how do you test clinical judgment? Sometimes in the testing world, clinical judgment or any kind of judgment or decision making is what's thought of as a soft skill, right? Communication, reasoning, problem solving. And these aren't just in nursing. My background in math, when I did math tests, things like mathematical reasoning, mathematical communication, soft skills, hard to test. We maybe wanted to test them. They were hard to test, especially with things like multiple choice items. Almost always you had to come up with something a little fancier. And that happened to us here with Next Generation NCLEX as well. But the point is, clinical judgment, hard to test. Good news, the breakthrough of the clinical judgment measurement model is down here at layer 3. It essentially identifies 6 component skills, sometimes we'll call these cognitive operations, associated with clinical judgment that essentially add up to the whole thing. If we can test these 6 things, we can feel pretty good that we're getting a very comprehensive measure of clinical judgment. And the good news is that each of these 6 things, you could still call them soft skills if you like, but for each of these 6 things, we at NCSBN, in fact, did find ways to measure them. So these 6 boxes, starting with recognize cues and going through evaluate outcomes, really, I call it the decoder ring of the entire exam. If you were here 2 weeks ago, we covered this quite a bit, but if you're new here today, let me state something really important. Every new clinical judgment item being added to the exam hits one of these 6 boxes, right? So it's a really, really important row, not just for the item developers or the educators like you who come into our item writing workshops and write for the Next Generation NCLEX, but also just as faculty, as educators, to know what are your grads going to see when they see clinical judgment. They're going to see a lot of questions that cover these 6 boxes. Okay, let's tie it to the case study. Well, the case study is a real world scenario, right? Something that an entry level or new nurse might encounter, followed by 6 test questions. The number 6, not a coincidence. You see these 6 boxes? Well, those are your 6 test questions. Not only that, but in this exact same order. So that's the case study from a measurement perspective. Scenario followed by recognize cues item, analyze cues item, prioritize hypotheses item, etc., all the way to the 6th item, always in that order. So what I like to do is show it a little bit visually. We have these posters suitable for framing. I've heard some folks print them and in miniature and put them on a key ring or use them as bookmarks or something like that. But at any rate, we essentially have these posters that define those various terms within the 6 boxes. And what I'd like to do, though, is represent each of these things a different way. Sometimes educators, and I'd say definitely students, look at recognized cues, analyze cues, etc., almost like new foreign things that we've created to put on the NCLEX and test that are sort of above and beyond and different from the kinds of things that would normally be focused on in their education programs. So really let me redefine using, I'll say, much plainer, simpler, friendlier vocabulary to highlight the importance of these things and show that these are, in fact, survival skills for new nurses, new grads, if not for their patients as well. What do we mean when we say recognize cues? First question in a case study is, you just read a whole bunch of stuff. You just learned a whole bunch about this client situation. There might be 100 things here, but what matters most right now? What matters most right now? Thinking about yourselves as educators, experienced nurses, this has been my experience working with you, is you glance at our scenario and instantly you're in action mode, right? You know what's going on. You know what's needed. You got one hand ready to do one thing and the other hand ready to do something else, right? And then you get your backlog of, and then when I'm done with those, I got to do this. This is the benefit of your experience. And probably the more information, the better. For new grads, for new nurses, sometimes too much information can be paralyzing. Instead of springing into action, it's like, oh my gosh, here's all this stuff. So what matters most, or what matters most right now, really a valuable skill for new grads, and the first of the 6 boxes, we'll call it, in our clinical judgment framework, where every case study starts. Now, from that, you want to know, do my grads know why these things matter? And that's really all we're doing with the second question. We're going to write a case study together today. This is what we're doing. What matters most right now and why? From there, a little bit of a curveball, I like to say, because the third question in the case study can actually go in 2 different directions. One of them involves hypotheses, explicit hypotheses, like what could be happening here is this because of this evidence, right? Or the most likely explanation for X is Y, something like that, right? Hypotheses. Um, Often, though, what we see here, a little bit different because the hypotheses may be implicit, not directly in the item, is so let me call timeout. I'm seeing a few of you in the comments telling me that you're not seeing the screen. Uh, if you can, yes, see my screen, let me know. Type yes if you can see my screen. Okay, I'm definitely getting some yeses. So one of the things that I'll offer is, I know within the Teams meeting, sometimes you're able to choose your view. Since I'm in presenter mode, I don't have the buttons in front of me. It looks like most of you are seeing it. I would say if you're able to choose your view, it may be that you'll want to shift from something like attendee gallery to more of a default setting. I'm not too sure, and I don't want to put too much on my host Randall, but I wonder, Randall, if I were to continue, if you might uh, maybe offer an idea or two in the chat for folks. Um, but it looks like almost everybody's seeing it, and on my end, it's certainly showing up as shared. I'll take a quick drink for the throat, and then we'll look at part 2.
Yes, I will see what I can do.
Okay, I appreciate that, Randall. Okay, yeah, I am seeing a few no's. I'm definitely seeing a few no's. So thank you in the chat for alerting me. This is important. Definitely for our use of the action model, you're going to want to see the screen. It'll be a lot to keep in your head otherwise, I think. So prioritize hypotheses. Third question in the case study, I mentioned there's a second direction that it often goes instead, which is simply, I call it, where do I start, right? Longer phrase I sometimes use is prioritizing some aspect of the client's status. So maybe there's pain, but maybe there's difficulty breathing. Maybe there's something else as well, right? Well, where do you start, right? In that case, you might not in the item directly see hypotheses, but what Maybe there are some underlying hypotheses. Either way, you definitely would see prioritization. So, keyword prioritization, third question of every case study. When we go to the second half, it's all about solutions, actions, etc. Fourth question is always essentially the same. What could help here? What kinds of things could help the client? From there, okay, what am I going to do? Right? It may be all of them, by the way, but it might not. Right? Well, for pain, maybe it's these meds, or how about breathing exercises, or repositioning, or you got choices, right? So at this point, what are you going to do? Sometimes, how are you going to do it? Again, a little bit of a curveball. We could go two ways. We'll see that, by the way, as we create our case study today. And then how does every case study finish? Evaluate outcomes, plain and simple English. How'd it go, right? Did some things get better? Did some things get worse? Did some things stay about the same? So, why the slide in front of you? For those who are lucky enough to see it, why do I put it in front of you? Well, this is me saying, yes, we have some specialized testing vocabulary associated with the case studies and the clinical judgment measurement model. But fundamentally, what are these? These are really, really important, critical questions that new grads working as nurses need to be able to answer as they're working with clients. So, okay, let's talk a little bit about the scenario. The scenario, then, the real world scenario, being the information that we're going to ask those 6 questions about. So I'll have a little bit of fun with myself here. This is off the record. I know I'm not being recorded. Oh, I am being recorded. No, okay. I'm teasing. We're gonna have a little bit of fun. So I have had educators come up to me in the past. I've been working with the NCLEX since 2010, so it's been a while. I have a lot of educators in those 13 years say, Jason, the NCLEX isn't super real world. We call it NCLEX land. Every client has one issue, one thing wrong. They need one thing done. I don't know how real life that is, right? Well, I know none of you think that, or we wouldn't have invited you today. No, I'm teasing. But anyways, that is a little bit of a knock that I hear sometimes about the NCLEX. Well, when we're thinking case studies, oh, that is not going to be the case at all. When we're thinking case studies and our real world scenario, you can bet there are going to be multiple issues, multiple needs, right? And that's how some things are going to be more urgent than others. There's going to be a need to prioritize in terms of the information presented. I put it in 3 categories. Now, you as educators and nurses could put it into 4 or 5 categories, probably. My 3 categories that I use, and we'll do this with our action model today, are the things that matter a lot right now, the things that matter, but they're a little bit less urgent, kind of back burner. And then there's always some information that you don't really end up needing to use, right? So those are 3 kind of logical categories that I put information in. And the scenario, the real world scenario, generally will have a mix of all 3 because that's real life, right? So I'm going to be providing a scenario that we all use together today. It actually won't be this one that I'm putting up here. This is simply to illustrate typical case study scenario. There's a lot going on, right? You can see here 4 tabs worth of information. We've got nurses' notes, history and physical, vital signs, lab results. I always emphasize that 4 is not a magic number. This sample, 4 tabs. There's another sample we use quite a bit in my presentations that starts with 4 tabs. Nothing magic. Some start with 1 tab. In fact, the one we're going to use today starts with 1 tab and eventually adds a 2nd tab as we go further along through the case study. But what do I want to highlight here? At a glance, you can see it. There's simply a lot of information, right? Real world, right? Lucky is the new nurse who walks in and here's the 2 things you need to know, right? More likely, here's a lot, right? or maybe they start out with two things and learn a whole bunch more early on. But at any rate, there's always a lot of information at some point. What else? I really like the bottom left tab, the history and physical, because it also shows the range of content that can make it into the scenario, right? If you think of a typical NCLEX question, you might say, oh, this is a psych question, or oh, this is med surg, or something like that. If you look at this here, right, we've got some psychosocial cues or findings, right? So we could say, oh, okay, so this is psych. Well, okay, maybe a little, but look, there's also other stuff too, pulmonary, right? Endocrine, right? So, and that's common to a case study scenario as well. Final thing I'll point out, just because I'm here to share as much everything I know about the exam, not just the action model. I'll point out something that may be a pleasant surprise or new to some of you, and that is on the bottom right-hand corner, you see that we give a lab value for serum glucose, and then we also give the normal or reference range. So that is a new change coming to the NCLEX April 1st. When all the next generation changes come, the case studies, clinical judgment, all of that, whenever a lab value is given, the reference range will be given as well. And while that is true within a case study, it's also true across the rest of the exam. Even a multiple choice question, if there's a lab value, there's a reference range. So that may be something that's new for you that you learned here today. If not, I've got plenty more that will be new. So, okay, with that, we're going to take a look at the action model. Again, we have a newsletter on it. I'm going to say, I hope I'm not making too bold a statement. The newsletter is very informative and kind of tells you all about the action model, but I would say what it doesn't necessarily do is put you in a position to actually write your case study based on what you learned from the newsletter. That's where you need me, or that's where you need the annotated action model. So I think I'm giving you something extra beyond what's in this newsletter. So what is the action model? If you've got that horizontal piece of paper, right, you're looking at my annotated version. If not, I'm going to be showing you on screen regardless. So think of it as a template. It's a template for creating case studies that fit the NCSBN clinical judgment measurement model, or more importantly, that look like the ones on the NCLEX. So, okay, here it is. We've seen it already. We know about that layer 3. There's a heavy focus on layer 3, because we know that's where every new question is written. Every new question is written to layer 3, but it also notes layer 4. Well, what's going on there? I didn't say anything about layer 4 before. Well, layer 3, we call those our cognitive operations. Sometimes I get a little lazy and I just call them our clinical judgment skills, right? Okay. Layer 4, maybe not readable on your screen. I'd have to really squint even on my own. We just call that context, right? So every situation has its context, right? Where is the nurse? Where's the client? Who's with the client? Things like that just add a little bit of color and flavor to the case study. So we will hit on those shortly, but for now, just know that we're interested having these 6 skills tested, but also having enough context in the scenario to feel real life, real world. So I'm going to now use 2 metaphors to speak of the action model. We can think of it, if you like cooking, as a recipe. It combines these ingredients from your scenario and turns them into a case study. Or we can think of the action model as a bridge. That's my other metaphor. It takes us from the clinical judgment measurement model, and it's okay with me if you think researchy, theoretical, academic, abstract. It takes us from that to the case study, which is very hands-on, practical. It's going to be on the test, right? You name it. So it's going to take us from this thing on the left, where if I said, Now write me a case study. You might say, okay, let me think for a while, right? It's going to take us to the case study with some help. All right, let's jump in. If you have that horizontal handout handy, it won't look exactly like this, but it's essentially what I'm referring to now, our action model template. So first, I'm going to show you the action model as it was first published in 2019 in a journal, at any rate. I think it was in our newsletter even before then. But mainly in this view, I just want to point out that it has 3 columns. The first, cognitive operations, is that layer 3. So you'll see recognize cues, analyze cues, and so on, all the way down to evaluate outcomes. Now, when we use the action model template to write our case study, we're essentially going to be filling in these 3 columns of information. But here's the good news. The first column is already filled in for you. It's always these 6 things. Okay, now let's go to that second column. It carries what to me feels like a rather researchy heading of factor conditioning. Underneath it says, oh, we're just talking about layer 4 of the clinical judgment model. Okay. Well, in other words, context. Okay. Well, we can kind of see what's meant by that as we go down the second column and we see things like environmental cues. Oh, location, we're at the ED. A parent is there. Got it. Client observation cues, etc. Right? So the kinds of information that's coming out of the scenario. The third column is where the magic happens. If you just look at this one right now, if you look at this third column, you probably don't see 6 NGN items yet. However, when you get through this training, you're going to see that, in fact, this column of the action model template, especially the annotated version, gives us our 6 items. So, anyways, at the moment, 3 columns. First one is that layer 3, those 6 cognitive skills that make up our clinical judgment framework. Second column, a bunch of interesting things out of your scenario, almost like you're taking notes out of your scenario. Final column, where the magic happens. More on that later. Now, again, I took this from the research journal, and this will not be the content we use today. I just wanted to show what the action model looks like as published. Now, here's the handout that you have. Here's the annotated version. Same 3 columns. It's a little small because I wanted it to fit on one piece of paper for you. So obviously, if you were to start typing into it, you might end up on the second, third, or even fourth page. But recognizing it's small, I'm just going to blow some things up. Let's take a look at the second column. And here's where I've done some annotations for you, right? So let's pretend that you've drafted a scenario. Well, then you can take these notes. Where's the scenario taking place? Doesn't have to be ED, by the way, right? School nurse's office, for example. Who is present? And you put that down. Any other information that you'd consider under environmental cues, feel free to list that as well, right? Client observation cues, you get the idea. So the point is here, rather than giving you a blank piece of paper to just fill things in, right? I've kind of organized it, I've prompted you. And then one of the things that happens that I think will be helpful for many of you, or let me give a tip actually. So far, as you're thinking about how we develop the case study, you'd be correct if what you think you've heard is you're going to write a scenario first, then you're going to pull out the annotated action model template and start answering some of these questions, taking some notes, essentially. That is the process I'm describing, but I'm going to give you an even better one, which is just to approach it iteratively. What do I mean by that? You write your scenario. Now you go to your action model template, and let's just pretend, maybe this is a bad example, but we'll pretend that you get to where is the scenario taking place? And you say, oh, you know what? I forgot to put that in my scenario. I guess I'll skip that question. You could, but even better, let's go iteratively. You look at that and you say, oh, yeah, I should have something. Let's make it community health fair. And then you go back to your scenario and you edit it, right? In other words, you probably write your scenario first, but it's not etched in stone. It's not locked down, right? You write your scenario, you go to your action model template, and one of the things that my prompts can do for you, if you like, is encourage you to make some additions or revisions to your scenario, right? So if you treat this as an iterative process, you may end up with a richer scenario. Now, don't get me wrong, there may be some of these things where you intentionally don't have them, right? So you don't have to answer every one of these questions. However, I think it's nice if you see one and you say, "Oh, I wish I included that," that you go back and add it rather than just regret your scenario. All right, probably enough on that for the moment. Let's take a look at the all-important third column. I've blown it up a little by the magic of PowerPoint magnifying glass technology. So, what's going on here? Well, here, instead of just leaving a blank box for you for expected behaviors and actions, I've created some prompts that really go nicely with the clinical judgment skill we're interested in. Let's start with the heading, by the way. I've covered it up with the magnifying glass, but it's expected behaviors and actions. This is really you as an educator saying, given this information in the second column, what would I expect my new grad or even the new nurse taking care of me, right? To notice, figure out, understand here, right? That's what this column is all about. As we go further down into things like generate solutions or take action, the expected behaviors and actions will be more like, what would I expect that new nurse to do in this situation or to recognize as a possible thing to do in this situation? So, uh, but we've got these prompts. Remember, I said we can think of the information in our scenario in three logical categories: things we need to care about right now, things we could maybe come back to later, probably important, but not burning issues, and then things that maybe aren't going to matter to us too much in the care of the client. Three categories, and I've got these three prompts. So I believe it's time for me to deliver on a promise that I made, which was that column 3 is where the magic happens. It essentially writes your item for you. Let's see if that happens. We're going to give it a try. We're going to apply the annotated action model. So if you have the vertical piece of paper next to you, you've got the scenario we're using today. If you don't have it next to you, not a problem at all. I've got it right here. This is initially the scenario. More will be added later. A new tab will show up with some diagnostic results, but at the moment, this is our scenario. Nurse in the ED caring for a 41-year-old male. And at 11 o'clock, the nurse's notes state client reports nausea, loss of appetite, vomiting, fever, constipation for the past 2 weeks, abdominal pain 7 out of 10. Client states the abdominal pain started after my 7-year-old child accidentally kicked me in the stomach. Client plays soccer with the child once a week. And now let's look at the vitals. Temperature 103.4, 39.7 for our Canadian friends. I think that's going to be high in both countries. Pulse 92, respirations 22, blood pressure 130 over 86, oxygen 98% on room air. No past significant medical surgical history, BMI 32. Alcohol socially, usually 3 beverages, and smokes socially. So this is our starting point. What we're going to do now, we're going to write our recognized cues item. We're going to use the annotated action model template. And I've blown up that one box. I just showed it to you a few minutes ago, but I've blown it up and I've colored it orange for no particular reason. And now I'm going to challenge you. We're going to look at those three categories of information in the scenario, right? Immediate concern, important but not as urgent, and maybe less interesting overall. Those are our three categories. Let's go back to the scenario. If you have it on your piece of paper, you're good. If not, here it is. Use the chat and just let's tackle the first one first. What are the things you see here of immediate concern? Go ahead and type into the chat. Okay, so abdominal pain for a week, I'm seeing pain, fever, the blood pressure. I'm seeing a lot. Boy, the scrolling is happening fast. This is a great group. I've never had one where the chat is so fast. It scrolls so fast that I can't keep up. Okay, pain, fever, blood pressure, vomiting, uh, temperature 103.4. Great job. Great job, group. Okay, so fantastic. Now, let's look at our second category of information. What information here is important? We probably want to address it at some point, but it's not of immediate concern. Do you have anything like that? There might not always be, but go ahead and type in the chat if you think you see something like that. Okay, smoker, kicked in the abdomen. Okay, maybe the blood pressure fits that category. Okay, fever possibly. Okay, smoking, blood pressure. BMI of 32, nausea, the pulse ox, okay. Um, Hypertension, okay, constipation. So interesting. I will say we're seeing here, I think I've seen some findings that some of you have put in the first category and some of you have put in the second. There is going to be an important distinction there. We'll come back to it later, but at the moment, we won't worry about debating those things. For the moment, let's just acknowledge that each of you, and if you like suggestions from your colleagues, take those too. Each of you has some stuff that can fall into that first category of information, and you have some stuff that can fall into that second category. Now, how about the third category, if there is any? Do you see anything in the scenario? We hate to say, right, in the nursing world, oh, we don't care, right? We don't say that. It's a caring profession. But do you see any things here that you're just unlikely to have to worry about at all in treating the client? If there is anything, let me know in the box, in the chat. Okay, the BMI. Okay. Social drinker. Okay. Plays soccer. Okay. ETOH. I am being stumped. ETOH. Estimated time of.
That's alcohol.
Ah, yes. Okay. All right. Let's see. Yes, ETOH alcohol. Perfect. Okay, so social drinker. Good. Okay, and again, I think we've seen some overlap. So some of you put some things in this third category that others of you put in the second category. That happens sometimes as well. But at the moment, let's say that each of you has three lists, right? And how did you get these three lists? You simply filled in the prompts that I annotated into the action model template. Now, my PowerPoint skills aren't good enough that I can go presto, and you're seeing these populated with your suggestions. So we'll do some visualization. Whatever your three lists are, pretend that you see them on the left-hand side of the screen, right? And now let's see how this turns into our item. I've taken what I'm calling here an item skeleton, right? It's basically a question with nothing in it, right? Uh, but you can sort of imagine how we could add stuff to it and turn it into an item. Now, where did I get this? Well, at NCSBN, we have a lot of case study samples on our website. I'll show you where all that lives. The point is, one of the easiest ways to write a case study question, and I don't think it's cheating, and I'm at NCSBN, right? I don't think it's cheating, right? One of the best ways to write a good case study question is find a good case study question somewhere else and let it inspire you in this way. Say, you know what, I like that question. Let me cross out all their information and adapt it to my own situation. So in this case, let's see what we can do. We've got this skeleton question. Everything you put on your first list turns into your answer keys. You just copy them over. How about your second and third list? Well, those are your wrong answers, your distractors. You just copy them over. So I want to make a few notes here. But first, let's just see if this makes sense. So using the annotated action model template and this skeleton item that I've borrowed, do you see how your three lists from the action model template become your item? Go ahead and type yes or no. Okay, my quorum, by the way, is one. So I got one yes, we're good. Oh, I'm getting a lot of yeses. And okay, Fantastic. So now that you see how we've used the annotated action model template to create our first item just by responding to the prompts and copying them over into the item or the item skeleton, fantastic. I'll point out a few things. I may have given this tip last time as well. If we just copy them over, or I'm not sure which way you see me on screen, but if we just copy them over, what you'll have is the right answers on top and the wrong answers on the bottom, and your students are going to figure you out quickly. So in fact, after we copy them over, it's a good idea to shuffle, right? Sometimes on the exam, not always, but sometimes on the exam, we sort the answer choices shortest to longest, and that has the effect of mixing the keys and distractors together. So that's the first thing I want to remind you of is whenever you think logically about your item, you write your item like an item writer would, come up with the right answers, then come up with the wrong ones. That's great. That's logical. That's the best way to do it, as long as you remember to shuffle at the end. Sometimes people don't write their item that way. They say, I'm not really going to come up with my right answers and then my wrong answers. I'm just going to come up with anything that I think would be a decent choice. Okay, that could work. Sometimes what happens when people do that is they accidentally end up with an item with no right answers, or sometimes an item with no wrong answers. So I prefer, right? I prefer, in my experience, the logic of start with the right answers and then move to the distractors. Okay, couple other things I'm going to say. I spend the most time on our first item because it really sets the table, right? We want to be really good at this one in order to move on to the next five, some of which will be a little more difficult than this one to do. So, what else do I want to say here? I mentioned there was a little bit of debate or a little bit of discrepancy for some of you, something like blood pressure. I think some of you put in the first category, some of you put in the second. Alcohol, I think some of you put in the second category, some of you put in the third, right? There's a little bit of debate, let's say, on this call. Okay, first let's talk about things where you're not sure if it belongs on the second or the third list, right? Let's just take alcohol as an example. Maybe we don't know if alcohol is second list or third list. Here's the good news. It actually doesn't matter because either way, it's simply going to be a distractor. That's it, right? So it's kind of like your scratch work. When it actually hits the item, it's a distractor. It doesn't matter if it came from the second list or the third list. Either way is good. So you don't want to lose any sleep. Don't lose any sleep. Oh gosh, I just don't know if it was second or third list. Is this going to ruin my item? No, it doesn't affect your item at all. However, distinctions between the first and the second list do impact your item because we're talking about the difference between a key and a distractor. That's a very important difference in testing, right? We don't want to accidentally mark somebody wrong for choosing something that's correct. So that's a little bit trickier. What I'll say here is if you find yourself with a particular cue, I think for some of you, blood pressure made the first list, and for some of you, blood pressure made the second list. You don't really want that in your item. So what would I do? 130 over 86, I'd probably change the blood pressure, right? I'd just go ahead and change the numbers, right? For instance, 119 over 86, right? You'll have to decide if that's clinically compatible with the other findings or whatever. But the point is, 119 over 86 will breathe a sigh of relief. It's now a distractor for sure, right? Or by the same token, maybe 190 over 112, and now you can comfortably put it in that first column and not worry, right? So the point is, I do want you to worry if you're not sure if something goes in the first or second column. You do want to have that very clear. And for me, right, with the NCLEX, I really need to be sure people get lawyers, right? If we get too blurry in distinguishing keys from distractors. So I don't mean to scare you away from writing these case studies. And sometimes, by the way, if you have something borderline, if you're not sure, right? If you say, oh, it could be here, that's fantastic classroom discussion, right? Maybe the blood pressure as is. What do you think, students? Do you think that's of immediate concern? If you do, how come? If you think it's less urgent, how come? Right? There could be a great conversation. All right. I've probably covered everything that I want to cover with this particular item. I will note, and you all know as test takers, when you used to take multiple choice tests, sometimes there's a distractor or an answer choice you could cross out quickly. Oh, I know it's not that, right? And sometimes you're left trying to figure out the key, the right answer to your multiple choice. You're looking at a couple and it's kind of like, oh, I don't know if it's this or this. Ooh, right? Well, when I talk about strong and weak distractors, that's what I'm talking about. And so as you see these things, generally things you copy from your second list are going to be kind of tougher for your students. They might look at it and go, ooh, I'm not too sure. Huh, maybe, right? Generally, the things on your bottom list aren't going to really fool anybody. Your better students pretty quickly should be like, okay, yeah, I know it's not that, right? So in the testing world, we talk about distractors as being plausible or implausible, but another way to think about distractors is strong or weak. And in my opinion, a good item will have a mix of some stronger and a few weaker, but I wouldn't put anything super obvious, right? I wouldn't put something super obvious wrong because then it's just taking up space. Um, final thing I say, final thing I'll say on this item. Let's pretend you do this and your lists are really long. You've got 5 things in each of your 3 lists. You've got 15 things total. You probably don't want to write an item with 15 choices. I mean, you could. On the exam, we won't go past 10. 10 is our maximum number of choices. This template only has 7. All good. Choose your favorite 7. Choose your favorite 10. In other words, just because you wrote it down, it doesn't mean you have to use it, right? You've got a lot of latitude when you're writing items. Okay, with that, we're going to move to analyze cues. We're still on the same scenario. Nothing new yet has happened, same information. But remember when I talked about the case study in plain simple English, the second question is kind of a why. Okay, why is this stuff important? What could it mean, for example? I'm going to call your attention to the right half of the screen first, where we've got our sample item or our item skeleton. Well, we took out all the content, right? There's no nursing terms left in it. But what is it? For each client finding below, click to indicate if the finding's consistent with disease process of X, Y, or Z. Each finding may support more than one disease process. So for this item to get off the ground, we need 3 conditions, X, Y, and Z. Well, what's a condition? COVID, pneumonia, etc. So, but we'd love to have some things that fit this particular client situation better. It doesn't mean this is exactly what's wrong with the client. Doesn't mean that. But what are some things that, let's say, your better students might at least think about for a sec? They might rule it out, by the way, later on, right? But what are some things, and go ahead and use the chat as always. Tell me a condition that comes to mind with some of these findings or cues. What's something that at least your students might think of as a maybe in this situation? I mentioned COVID, but there's probably not a lot of COVID stuff going on there. Okay, appendicitis. Okay, I like that. Diverticulitis. Okay. Yeah, I always get a lot of itises when I do this. Look at that, peritonitis, right on cue. Okay. I'm jotting these down because I'm going to need to remember them because we may use them quite a bit. Okay, and also splenic or spleen laceration. Okay, I'm also seeing sepsis. I'm going to go ahead and sort of cut us off here. I'm going to cut us off of 3 drinks or four in this case. I love it though. These are fantastic. And the fact that you gave me more than 3 gives me another itis. You're just having fun with me. Gastroenteritis. Yes. Okay. All righty. So let's go back to our item. I'm going to go ahead and just choose, right, on behalf of our group, I'm going to choose appendicitis, diverticulitis, and then I'm going to choose splenic laceration, just so we don't have 3 itises. But okay, if you're doing this, right, if when you're on your own, not in this workshop, you could add a 4th column if you really like 4. If you look and you say, hey, I've got 4 conditions that I'd really love to be able to test here, you could have 4, right? Maybe right? And maybe you're teaching newer students. Maybe you just have two. That could be okay too, right? There's some flexibility here. I was inspired by a particular item in one of our sample packs. I grabbed it. It happened to have three conditions. So we'll go with appendicitis, diverticulitis, and splenic laceration. And now we're ready to go over to the annotated action model template. So condition X, appendicitis. I'll go back to the scenario. What are some cues here that might go with appendicitis? Go ahead and use the chat. Type in some things that could go with appendicitis that you see here. And this is important if you want to be like NCSBN, stuff that you see here, right? Don't give me something that's appendicitis, but it's not in the scenario, right? If it's not in the scenario, I don't really want it as much. Okay, temperature, vomiting, pain, fever. Okay, so we're getting a lot. Loss of appetite. Wow. Yeah. Okay. 103.4 temperature. Good. Uh, okay. So we see a lot. You got a lot. By the way, let's remember one thing that I just said. I said, oh, we don't want it if it's not in the scenario. But remember when we talked about an iterative process, right? I don't know if this is still true. I apologize, y'all. My background is math and testing, which is not nursing. So, the amount of nursing I know, I've learned from groups like this when I present. But I remember, I think when I was a kid, somebody told me, like, if you had appendicitis, it might be painful to raise your knee to your chest. It also turns out if you're over 50, it's painful to lift your knee even past your waist. But at any rate, let's say that you wanted to include that, right? Pain when raising knee to chest. And you say, oh, darn, it's not in the scenario. Jason won't let us use it. Well, guess what? You could actually work iteratively and you say, you know what? I'm going to put it in the scenario. Okay, go to it. You do that. I support you, right? So anyways, we've got so much great stuff. So, oh, Karen tells me I got it right. Okay. So now remember, and I won't go back, I won't toggle back to our action model template. I'll just remind you, the second thing it tells us to do is start listing some of the signs and symptoms from the scenario that would be consistent with our second condition, in this case, diverticulitis. So give me some diverticulitis. And by the way, I won't be shocked if you give me some stuff you just gave me for appendicitis. That's allowed. Give me whatever fits diverticulitis out of this scenario. Okay, pain again, temperature. Okay, nausea, vomiting. Okay, the constipation. Good. I'm avoiding the NV that people keep typing because I can't remember what that stands for. Right. So okay. Good. Okay, pain, temperature, nausea, because the nausea and vomiting. Thank you. Thank you. Thank you. Thank you. The sad thing is I just got that from a group yesterday and I forgot it already. But okay, excellent. So great job. And now you'll remember the annotated action model template also gives us a chance to list cues associated with the third condition. And I've chosen for you splenic laceration. So what do you see here in the scenario that goes with splenic laceration? And again, you're probably going to tell me some of the same things as before, but you might have some new ones too. I don't know. Okay, abdominal pain. History of injury, okay. Pain or abdominal pain, okay. Hypertension, kick in the belly, elevated vital signs. Ooh, I like that. Loss of appetite. Okay, so here's what we're gonna do. We're gonna go back to my item, and you're gonna again visualize, right? We're gonna visualize that you've now populated these three lists, one for appendicitis, one for diverticulitis, and one for splenic laceration on the left-hand side of the screen. Certainly, there are a lot of cues that you've listed for all three, and that's okay, right? That's allowed. Anyways, what you're going to do is you're simply going to choose some of the cues from any of your lists, any of those three lists, and you're just going to copy them over onto the right-hand side as client findings. Now, something important to know. Let's pretend, I can't remember if it's true, but let's pretend that pain 7 out of 10 was consistent with all three. Let's pretend that that made all three of your lists. You're not going to copy it over three times. You're not going to fill in the right-hand side with pane 7 out of 10, pane 7 out of 10, pane 7 out of 10. No, 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 no. You're going to do pane 7 out of 10, and your students, if they know their stuff, are simply going to check it off maybe all three times, right? When they respond to the question. So that's important. Don't copy over the same finding more than once, but essentially just copy over your favorite findings if you like, and then I'll give you some tips for style points if you like. So how can you earn style points from Jason? Well, really it's about how can you have kind of a fun question to see what your students know with respect to this clinical judgment skill. But we'll take style points too. So let's go. I think it's kind of cool if you've got a finding that checks off all three conditions. But I also think it's kind of cool if you have findings that don't check off all three. In other words, a mix. So I believe, I didn't totally keep track, but I believe that as we did this exercise, many things got listed in all three, right? Many cues got listed consistent with appendicitis, diverticulitis, and splenic laceration. I think that happened, right? I wouldn't make the whole item that way, where you've listed 5 or 6 of these things, and the answer to all of them is check all three. It's actually a valid item, but I'd say for style points, having a mix. Now, what happens if, okay? And again, I didn't keep track, so I may be chasing down a red herring here. But let's pretend that you do this and you say, gosh, Jason, everything we listed, everything in the scenario really does fit all three. Well, then you can't get any style points unless, always as an item writer, we try to be flexible. We say, oh, we don't like where we ended up. How can we change this? Well, remember somebody suggested peritonitis. There were a lot of other possible conditions we could use. So in other words, if some things that you've come up with, 4 things that you've come up with that seem to be consistent with every single cue, well, you could trade away one of the conditions for a different condition, and then maybe you'll get a little more variety. That's all. Okay, but let's go back to the chat. This item, we had to do it in 2 phases. I'm going to say it was a little more complex to put together than the recognized cues. But give me a yes if it makes sense. Give me a no if it didn't make a lot of sense. I'll take care of my throat. Okay. And Randall, I may ask for an assist. I'm actually not seeing anything in my chat from that. Either yeses if this second item made sense or no's.
Everyone has said yes.
Everyone said yes. Okay, gosh. So my chat seems to have stopped. So I may need to rely on you a little bit more as we go. We'll see. But that's really good news. So we're going to go to the third item, prioritize hypotheses, and people maybe remember from earlier today or from 2 weeks ago that prioritize hypotheses items can go in 2 directions. They can really feel like hypotheses that we're going to prioritize or support, or sometimes our focus is really on the word prioritize, and it's just about how are we going to prioritize our attack, so to speak, our care. Let's not say attack. We don't like that for nursing. Okay, so let's take a look. The item that I was inspired by, my item skeleton here, seems to be that second version of prioritize. In other words, the nurse should first address or worry about this thing going on with the client, and then worry about this other thing. Well, if you look at your annotated action model template, it kind of allows for both approaches. I kind of wish I put a dashed line after that first bullet, because that first bullet fits the item that would be looking at explicit hypotheses. The second and third bullets fit what we're looking at here. So even though there's three bullets, we're going to jump to the second and third because that's what fits this item. So this is interesting. I used this same presentation yesterday and I actually got some disagreement. I'm going to call it healthy disagreement because it allowed me to share some really good extra information with the educators in the audience. So let's try this. Go ahead and tell me from that particular client the thing that should be focused on first. Go ahead and use the chat. And Randall, if I'm not seeing anything, I'll rely on you.
Pain and fever are coming up, mostly
Okay.
pain.
Okay, perfect. You know what? Yeah, my chat seems to have stuck. I'm just going to share a funny story and then hope I don't run out of time later. So here in Illinois, I'm not too far from I think it's like the wrong Reagan. At any rate, when I was there, the guy told a story. He used to be an announcer for Notre Dame football, before he went into acting and politics, just a young announcer for Notre Dame. And they used to get a feed from the stadium, I guess, of what happened on the play. And then, he would describe it as if he were watching the play, but really he was just getting the ticker tape or the Morse code, or you can tell I didn't pay perfect attention at this presentation. But at any rate, well, one day he was doing a baseball game. He was doing Chicago Cubs. Same thing. He'd get this little feed coming through that would tell him what happened. And then, he would announce it as if he were watching it live. Well, the feed stalled. He didn't get anything for 5 whole minutes. And rather than acknowledge the technical difficulties, right, and sort of reveal the game, instead, he said to the audience something like, and Cavaretta fouls off another pitch. Wow, and another foul ball from Calvaretta. So he just kind of invented foul ball. So here I am. I was thinking because I knew everybody yesterday told me pain and fever. I thought, well, I'm not seeing anything in the chat. Should I just say, oh, good, pain, fever? But no. Okay, Randall has me covered. End of detour. Back to it. So I love this. We've got pain, we've got fever. And so interestingly enough, let's at the moment pretend that we write both of those down with that second bullet. I know it says prioritize the condition, but let's write down pain, comma, fever. Let's pretend, let's visualize that. What are some things about this client that we can come back to later? What are some lower priority things? No need to tell me pain and fever because we've kind of got those noted. Uh, what are some lower priority things? And Randall, let me know what you see in the chat.
Blood pressure, respiratory rate,
Beautiful. Okay. Anything else coming through?
nausea,
Nausea. Okay, I'll take it. So
vomiting.
okay. We'll pause there. We'll pause there. So interesting, if we think about writing our item, copying things over, well, if we keep the item as is, the nurse should first address, we actually run into a little bit of a problem, right? If we can't decide pain or fever, right? Or maybe it's really close. Maybe some of you think, well, I do think I'd prioritize fever, but you know what? Pain is pretty up there. Some of you may see it as a tie. Some of you may see it as close. Maybe some of you are very definitive about which one you would choose, but I've got solutions for everybody. But how would we write our item? In other words, we would pretend we thought it was pain, definitely pain, definitely pain. Well, we'd make sure we got pain into this pull down menu. And then, of course, we'd go to these lower priority things and populate the rest of the menu. We could have 3 choices, we could have 4 choices, we could have 5 choices. So in other words, if you have a lot of stuff you like, don't limit yourself because this sample has room for 3. You could add a 4th, right? You could add a 5th. Well, what would we do next? Let's pretend that we really, really knew it was pain. Pain number 1, fever number 2. Well, perfect. This item is made to order, right? Our second menu, of course, we would put fever, and then again, we could grab some of these lower priority things. Makes sense. Now, some of you are saying, okay, that's great, Jason, but we think pain and fever are kind of tied. Here's the good news. Here's how you'd fix this item. the nurse should first address the client's menu and other menu. In other words, the sort of fill in the blank approach to this item would ultimately say the nurse should first address the client's pain and fever. Make sense? Somebody give us a yes.
Lots of yeses.
Oh, I'll take it. I'll take it. So this is important to know as you're writing your case studies. Often you'll be inspired by an item in one of our NCSBN sample packs. You might be inspired by a case study one of your colleagues stumbled on, something that might come from resources that publishers have developed related to this exam, right? I just saw I saw a pretty thorough free resource that your neighbors to the north, Maryland Nursing Workforce Center, put together with a grant. It's something like 30 plus case studies free to all educators with answer keys and all kinds of things. So the point is you can get samples from anywhere and then you make them your own, right? So if you are inspired by an item that looks like this, but you say, "Ooh, it doesn't fit my scenario because I have a tie for first place," perfect. Just reword it, right? And if you're wondering, yeah, but do you ever do that on the exam? The answer is yes. The answer is yes. Sometimes there's a prioritized question that looks exactly like this, where there's essentially the thing you'd care about first and the thing you'd care about second. And it would look exactly like this. Sometimes there's a question with the and because it is kind of a tie for first place, right? And something to point out, let's pretend that you don't think it's an exact tie. You don't think it's an exact tie, but you will acknowledge that it's awfully close. That and solution still works. It doesn't have to be a virtual tie. As long as the first two things are the first two things in either order, you can use the and format of this item. Okay, so we have made it through the first half of the case study using the annotated action model template. 2 weeks ago, I talked about the first half of the case study as the nurse as a detective, right? Sifting through clues or cues, figuring out what's important, what these cues are telling us, et cetera. Nurse as detective. As we go to the second half, the nurse gets another job. I call it nurse as magician, right? Presto, we have attempted to change this client from however we encountered them to better, right? That was our aim. Nurse as magician will say actions, interventions, right? The whole bag of tricks comes into play here. So what I will point out, and for those of you on the piece of paper, the vertical piece of paper, you'll see somewhere that I've added this note. But this particular scenario, after the first three items, gets a new note. There it is. At 11:30, notified primary healthcare provider about client status, awaiting orders. Okay. Um, not a lot of substance there that we can sink our teeth into for item writing, but it's good to know what happened, and that's part of reality. Maybe we're not going to end up using that, but it's there because it happened. Okay. But it does allow me to share something with you. You don't see it in this item, believe it or not. Well, you'll believe it for sure. You don't see it in this item, but it's still true for the next generation NCLEX. You see the phrasing here, primary healthcare provider. That's been pretty standard with the NCLEX for a while. It kind of reminds me as a consumer of almost like an insurancy way to talk about somebody like a doctor, right? One of the things you'll see in case studies, or your grads will see in next generation case studies, is you may see more specific titles. So you may see pediatrician, nurse practitioner, surgeon, physician, etc. That's just something to know. It probably doesn't affect the right answer to anything, but the point is, part of being a little more real world is we're a little less generic with next generation NCLEX case studies about what we would call the primary healthcare provider. So sometimes you'll see that phrase like you do here, but often you'll see something a little more interesting and specific. Okay, on to item 4. Let's look at the right-hand side first. It's kind of a fan favorite. I'm not bragging because I didn't invent it, but I can say from presentations, people like this item type. What's it doing for each potential order, right? Our focus here, what kinds of stuff could help for each order, anticipated or contraindicated. Well, this item really will write itself when we think of the action model template, because it's going to say to us, consider indicated interventions, right? We expect the new nurse should consider some indicated interventions, but also be thinking about some things that the new nurse shouldn't do here or wouldn't expect to have done here. So let's go back to our scenario, and we'll use the chat and let me know what would be some indicated interventions that the new nurse might anticipate or recognize. All right, let's see. And Randall, I think mine's still broken, so I'll take any help I can get.
Labs, fluids,
Okay.
pain medication,
Okay, good.
starting an IV,
Yep.
CT scan.
Okay. All right. That all works for us. Okay. If you've got more, right? Now, is there anything you see here that would be contraindicated for this client? Sometimes that's a harder thing to think about. But are there some things here that might fit that category? That's what the prompt's asking us for. Can we come up with anything contraindicated? And Randall, let me know if you see anything.
Oral fluids, by mouth
Oh,
food,
mm-hmm. Yep.
anything by mouth.
Very good. Very good. I'll share, right? Sometimes you can know a whole bunch, right? This used to happen to me. I started writing math questions for exams. That's how I ended up where I am now, I guess, 26 years ago. And sometimes you can know a lot. I felt like I knew a lot of math. But boy, when it comes time to write your item, it's really easy to be like, oh my God, I can't think of anything, right? This will happen, even to the best of you. I will say this, one of the things I've seen as I work with different groups and we talk about orders, interventions, et cetera, right? Um, Somebody at some point has some kind of repositioning of the client or adjustment to the head of the bed where it's like a light bulb goes off and people are like, oh yeah, that's right, right? So at any rate, I always encourage every group, there's probably some position of the client or position of the bed that's either helpful or harmful here, right? So if you're ever stumped, if you don't have enough choices, you can always think about these, right? What do we get? We got Tren, Trendelenburg position, Hindenburg position. You know, anyways, you all know these things well. So okay, fantastic. So how do we write this item? Well, you don't even need me. You just copy your stuff over. And now let's see who was really, really paying attention. Let's pretend that I just copy my stuff over. I take the indicated interventions and I drop those into the first 3 rows. And then I take the contraindicated, I drop those into the next 3 rows. Am I done? Let me know if I'm done or if I need to do something else.
Linda's saying to make sure you shuffle them.
Perfect. That's exactly right. That's the missing piece. Always remember to do that, right? It's okay if you forget once, right? If you forget once, because nobody's figured you out yet, right? Nobody's figured you out. But if you always forget to shuffle, then there's going to be some giveaways on these tests. All right. At NCSBN, we never forget to shuffle. All right. Let's move on then. We're ready to do item 5. It's going to be called take action, right? So what's the nurse going to do here, or how's the nurse going to do it? But for better or worse, we just got a lot of new information for this scenario. Get ready. We got a lot. Let's start with the nurse's notes. 12:30. Client transported to radiology for abdominal CT. I think one of you anticipated that in the chat, by the way. So well done. 12:45. 20 gauge peripheral VAD inserted into the left hand. I think that was anticipated as well, right? That we were going to get some IV stuff going. Now, VAD site patent without signs of infiltration. We've got normal saline infusing at 75 milliliters per hour. How about at 14 o'clock or 2 p.m., as we say here in this household? The client reports sudden relief of abdominal pain. Fantastic. Or is it? We'll find out. Vitals, temperature 102.5, pulse 110, respirations 20, blood pressure 125 over 86. So we've got some changes. At 2:15, primary healthcare provider notified about client status, order received for additional CT scan. Client transported to radiology department. Oh, the insurance company might might not cover both. We'll see. I don't know. I've had bad luck when I do the same thing twice. All right. Anyways, on to the diagnostic results. Let's take a look at those two CT scans. The first one showed acute gangrenous appendix with calcified appendicolith. I like to joke that my team prepared this sample knowing I'm going to present it, and they said, let's just make it all nursing terms so Jason can mispronounce something. All right, 1445, second CT scan, right? Free intraperitoneal fluid noted, consistent with a ruptured appendix. So, wow, back when y'all were typing appendicitis, I think you had a good guess there, or we won't even call it a guess, let's say. You knew what was going on. So, all this information, if you've got the piece of paper, it's there. If you don't have the piece of paper, we'll kind of lock it in, but I can come back to this page as needed. A lot of new information. Okay, take action. Interestingly enough, I think is the hardest item to write using the action model annotated template. The good news is, for many educators, they might feel like they don't really need our template because take action kind of comes naturally as right, or oh, the nurse needs to get started on X. So but at any rate, let's do our best here. The thing I'll say with take action, often but not always, is with take action, usually we've kind of narrowed down our focus to a particular thing that we're trying to do. So for example, the nurse is helping prepare the client for surgery, right? Or following the appendectomy, the nurse is teaching the client about whatever, right? So there's kind of like a focus that we've got. It's not necessarily all those different things, right? We might have anticipated 6 or 7 different orders, actions, interventions. Usually in the take action, we say, okay, let's go from that whole universe with lots of stuff to just one aspect. This isn't going to be everything that the nurse does with this client, but we're kind of focusing on one area. Uh, I wish, in fact, in my template, I said area rather than intervention. I feel like intervention's a little too specific. But anyways, so the nurse is focused on this one area, and now it's going to be about what things should the nurse do, and we'll have some wrong answers too. But I'm going to just ask you in the chat. I gave you a couple examples, some post-op teaching, preparing for surgery. Where do you want this item to focus out of all the things that the nurse could be taking action on? What kind of category, if you like, or area do we want to focus? It can be prep for surgery, post-op teaching, or anything else you like. Go ahead and type in the chat.
We've got preoperative care, postoperative care, prep for surgery.
Okay. All right. I think I like post-operative care only because none of the groups I've worked with have done that one yet. So it's a chance for me to learn something new. So let's do that. And I'm going to assume maybe the operation, I think, did we see that it was happening? Did we see that it was happening? Uh, I'm just looking real quick. Okay, yeah. So let's say that it's post-operative care following an appendectomy or something like that. Or I don't know. You all know better than me because some of you might be thinking, Jason, after the appendix already ruptures, you might be a little late for that. But we'll say some kind of surgery. Okay, so the nurse is assisting the client with post-operative care. I need to stay in my lane. I'm the testing guy. That's it. The nurse is assisting with post-operative care. So go ahead and type in the chat what kinds of things would go with that. What kinds of things would you expect the nurse then to do, right? How could the nurse assist with postoperative care? What actions could that entail? Let's see what you got in the chat.
See, assessing bowel sounds, maintain NPO.
Mhm.
Let's see. NG tube placement, pain medications, monitor for bleeding at the surgical site, pain
Love it.
management,
Love it.
assessing
Okay.
output.
Okay. We'll press pause on those. I love it though. I love it because why am I saying I love it? Sometimes I'll work with a group and they'll come up with something and then what actions and literally everybody will just list one thing and it'll everybody lists the same thing. Well, they would just do this one thing. Well, again, style points, right? Style points is we'd love it if we've got more than one right answer. So that's why I love it. You gave me a long list. Will we use all of those? Well, that's up to you. On the exam, we wouldn't have more than 10 choices. So if you came up with, let's say, 12 things that the nurse should do, what we might do, here's another technique. 2 weeks ago, I shared it, but I haven't yet today. There's something called clumping. There's something called clumping, where, in other words, maybe Randall read two or three things that kind of fit together into one little package. They kind of logically go together, right? Let's just pretend. I know you didn't, but let's pretend that you said, teach the client about healthy dietary choices, teach the client about good exercise to do. Well, you could imagine clumping those into, teach the client about healthy lifestyle choices, including diet and exercise. You get it? We could turn two things into one choice. If we ever had too many, we could do it. We don't have to. We could also just leave one out. But okay, fantastic. Now, we want some wrong answers too. So, in terms of assisting the client post-op, are there some things that the nurse should not do here? And we don't want to be too obvious. We'd love some plausible distractors, but let's just see what we get in the chat. What are some things that the nurse wouldn't do as part of assisting the client post-op?
Well, we either have silence or my chat is frozen.
Yeah, this could be a tricky one. That's okay. I'm gonna turn it into a teachable moment. Sometimes it happens, right? Sometimes it happens. One of two things happens. Either you say, "Oh gosh, boy, I can't come up with anything for that." Well, again, as an item writer, sometimes we say, well, let me do something that isn't post-op. Maybe post-op is why I'm not coming up with anything. Maybe I want the nurse to focus on something totally different in that case. So it could be that, right? That would be a shame because we had some really good right answers, right? So it would feel like a shame if we change our minds now. Um, sometimes though, sometimes you can solve it another way. I'm not saying this will solve it here, but sometimes as an item writer, this helps. Let's pretend, because right now we said post-op. Well, what do we mean? Do we mean like, 10 minutes after? Do we mean 3 days after? Right? If it helps to put a time frame, right? Maybe there are things that the nurse post-op day 3 should be doing that post-op, right away too soon, right? That could be, right? So that could be a way to think about this. Um, I'm guessing there was probably some anesthesia going, and maybe the client's not going to be awake and alert for a while or whatever. But the point is, you can sort of imagine, hey, if right away there's some things you wouldn't do, but you'd probably do them the next day or the day after that. Well, an interesting way to write this item then would be the nurse is assisting the client uh, 30 minutes after surgery, something like that. I'm speculating here, but let's pretend. Let's pretend 30 minutes or some kind of short time interval following surgery. Are there things that the nurse shouldn't do that soon, but maybe they'd come back and do later, maybe the next day?
So, so I got insert Foley catheter. I see
Okay.
deep palpation of the abdomen,
Hmm.
ambulate the patient,
Hmm.
water,
Okay. Okay.
clear
So
liquid
good.
diet.
Good stuff. Good stuff. Remember, I said take action. Sometimes it's the hardest item to write, and sometimes where it becomes difficult is coming up with the wrong answer choices. Funny story is when we had our very first item writing panel for next generation NCLEX, we had not yet settled on the idea that every case study would walk through those 6 boxes one item at a time in order. So the instructions we gave to educators like yourselves who came to our workshop in Chicago was go ahead and write your real world scenario and then follow it with 6 questions that make sense. And what we found, interestingly enough, was every single educator in the room, I think we had 10 people, every single one for their first case study, the first question was, what should the nurse do? The second question was, now what should the nurse do? The third question was, and then what should the nurse do after that, right? So in other words, the whole case study was 6 take action items, right? So to a certain extent, that's why I say take action sometimes is the easiest item to write because everybody was giving us 6 take action items. And, here we are now, we just want one. But okay, so let's move on to the 6th and final. But again, with this, sometimes you can hit a brick wall. So if it is sort of bad luck that the area the nurse is helping with just gets you to a point where you either have no right answers or no wrong answers, you could have the nurse focusing on some other aspect of the client's care. Or, like we did here, if it was helpful, right, you could say, well, let me put in some more constraints or specify it a little bit more because maybe there's some time distinctions that certain things the nurse should do now, whereas certain things the nurse should absolutely wait to do. Now, as we get to the 6th item, I think some bad things happen with the client. So be prepared, right? Okay. Nurses are resilient, if nothing else, so you're ready for bad news. Here we go. So the client is transported to the operating room for an open appendectomy. All righty. Now, let's call time out. Let's say you just wrote your take action item and it's about post-op care. Well, then this is going to feel weird. This is like a Back to the Future, time reversal, hole in the space-time continuum, right? Whoop. They already had the appendectomy, right? Again, if this is you, not a problem. You'd probably just have this thing show up in the scenario before the 5th item rather than after, right? So you got a lot of freedom here as you're doing this work, right? Iterative process, right? You can change things around. So don't worry too much, but we'll just go with what we've got here. So 1800, transport to the OR, open appendectomy. 10:30 p.m., transported back to med surge. And then 2 hours after that, client performing coughing and deep breathing exercises every hour while awake with the incentive spirometer, performing post-op leg exercises every hour while awake. NG tube removed, drinking clear liquids, abdomen board-like with diminished bowel sounds in all quadrants, rebound tenderness present. So we got all that. Our diagnostic results are still what they were before. Nothing new there. So you've got at, we'll say 2030 and 2230, or especially at 2230, a lot of really useful information. The other piece is just kind of giving you the where'd this person go information. Okay, so we've got all that. It's on your piece of paper if you have it. If not, I'll go back. Evaluate outcomes. For each data collection finding, click to indicate if the client status has improved, worsened, or is unchanged. So we're looking for good, better, worse, or the same, essentially. So our action model annotated template, I'd say fits the bill, especially the first 3 bullets. So let's focus on those. I'm going to go back. Now tell me some things you see here that are signs of improvement. Go ahead and use the chat. And Randall, I do think I need your help. Okay, signs of improvement.
Drinking clear liquids, deep breathing
Okay,
exercises, post-op leg exercises,
okay, good, good. We'll
incentive
take it.
spirometry,
Yep,
coughing,
okay,
deep breathing.
all good. Now let's pause on those. Let's pause on those Do you see things that are signs of getting worse? Anything, any cause for concern here? Anything that indicates uh, something bad?
Board-like abdomen,
Board-like
diminished bowel
abdomen.
sounds,
Oh, okay, okay. Diminished bowel sounds. Okay.
rebound
Uh,
tenderness.
and the rebound tenderness. So essentially the last three. Nobody shuffled here, right? We got the good stuff and then we got the bad stuff. But okay. So um, do we see, I'm not sure if we do, because I think we've just used up everything here. Do we see anything that's kind of a sign of no change? And we don't have to, but if somebody sees something, I'll take it.
Nothing's in the chat.
Yeah, yeah. I think when I've used this before, usually that one gets left blank, and that's probably the least important for us to have. I'll explain why shortly. So you can imagine now that we've filled in the first two bullets in the annotated action model template. That information that was in the chat, you could picture, just copy it over, right? We copy it over, we're good. Um, so rebound tenderness, we'll put that in. The answer is going to be worsened, right? Doing the leg exercises every hour while awake, we'll put that in. Improved, right? So you totally get the idea. Diminished bowel sounds, I think you said worsened. You get the idea. We copy our stuff over. Now let's pretend you look at this and you say, darn it, though, I wanted something unchanged. Again, we can work iteratively. We could, if we really want something that's unchanged, go back here and just add something, right? At 22:30, we could just add something else. Maybe it's related to pulse ox. Um, maybe it's giving their temperature again, and it's about the same as it was at 1400, etc. You get the idea. Um, maybe, and you'd know this, I wouldn't, right? If you add something just to be able to have a no change, try to make sure that it's clinically compatible with the other information presented. So for example, if I said maybe maybe have the temperature still 102.5, and you say, gosh, Jason, but we've already tackled that. Like, we got rid of the infection. Well, it's not going to be a temperature 102, then don't use that example. But the point is, grab something else. If you really want to have an unchanged, you can do that. Always we would shuffle. But I want to make a comment about the unchanged column. Some of you got this 2 weeks ago already from me, but I'll make it again here, which is for, at with the NCLEX. That's a column that very often we'll figure out we just aren't going to use. So we might use this item with improved and worsened, and that's fine. Unchanged can get us into a little trouble, and I'll give probably the same example I got before. Let's pretend originally somebody's temperature is 103.5. And now, you come back the next day and it's 103.4. Well, gosh, what is that? I would say, right, thinking like a nurse, which is not really what I should be doing, but I'll pretend, right, that if I were thinking like a nurse, I'd look at the client and I'd say, oh gosh, it's about the same as before. That's bad, right? Well, students, grads, they take the NCLEX, they choose improved because it went down by zero point 0.1, right? And we're like, no, come on, it's about the same, really, right? But the point is, in the world of NCLEX, people get lawyers, people take it really seriously. So you can understand that if there's even the most minute change, it's dangerous for us on the NCLEX to call it unchanged because that can be challenged. And it's hard to say, what a judge would decide, let's say. So that's a scary category to us. Now, in a teaching situation, I think you're okay, right? Maybe it's a teachable moment or an interesting conversation to talk about whether 1035 and 1034 are really different or the same, right? It's probably an interesting conversation. But in a high stakes test, that unchanged category is scary. And you could say to me, well, Jason, just don't do where it drops by 0.1. But let's say temperature was 1035 and now I make it 1035, that's a little too easy, right? That's too obvious that it's unchanged. So it's kind of a no-win for us on NCLEX, that unchanged column. It doesn't mean you would never see it. I will say that for the most part, we shy away. But in terms of lower stakes assessment, informal assessment, classroom discussion, it might not be a bad thing. This item, it kind of saved us because there was nothing. So we would just cross it out. Okay. With that, we have made it to the end of the case study. We've used the action model template annotated version. Again, if you started out with a blank one without my prompts, I think it wouldn't have been as natural to end up with the items. It would have felt like there's kind of a leap that you have to take and you're not too sure how to do it. So my annotations are designed, I don't quite want to say to have the item write itself, because I don't think it was that easy all 6 times. I think a couple of the times, maybe it was that easy, but using it on those easy ones, I think kind of helped us, kind of figure out, okay, what are we going to do here? We don't quite have our item, but there's hope. So, and it's particularly that third column of expected actions and behaviors that comes in handy, those annotations. Uh, uh,
Jason,
Now I want to add something because somebody could, yeah,
there was one
yeah.
question that said, would the unchanged column be on the NCLEX test if this is not an option in the answers?
Good question. Yeah, we could potentially use unchanged on the test, right? But I would say the real takeaway from my remarks is we would need to use it very cautiously because we would be very conscious of the fact that we had to, our test has to be legally defensible. So if we say something's unchanged, it really, really needs to be unchanged. And you couldn't make an argument that, oh no, it's actually a little bit better or it's actually a little bit worse. So we would use it sometimes, but with great caution. What happens though, a lot of times at our review panels, right, is maybe it's there because maybe the item writer included it. And then at the review panels, that's where a lot of hair splitting happens. People say, ooh, you know what? I know you say that's unchanged. It's actually a little bit better. I think that's going to get you in trouble. And then we say, got it. And we get rid of it there, right? But it could survive. It could survive. If it's well done, you could have an item where it is supported. So I don't want you to think you'll never, or your grads will never see unchanged. I'm just going to say, we have to proceed with great caution. Now, could you have that? Could we have unchanged in the item and it just turns out that none of the client findings are unchanged? In other words, the answer happens to be improved or worsened every time, but we still just have that column there. From a style points perspective, I wouldn't love it, but I would say the actual test items will always tell you. There's like a little note under the grid that tells you something like every column must be used at least once, right? If it says that, that tells you, okay, at least one of these guys is unchanged. If it doesn't say that, then technically the right answer could be that that column ends at blank. It could be that way. Not a lot of style points for me, but it could happen. All right, let me counter or address what if I were an attendee of this workshop, I might complain about a little. I might say, well, that's great. Jason's given us these 6 skeleton items that mostly fit this scenario, right? In one case, I think we turned those pull down menus into instead of first and second, maybe a this and this, because it was kind of a tie between pain and fever, but okay. But gosh, those 6 items, how representative are they of the entire exam? In other words, if we just use those 6 skeleton items for every case study we ever create, are we only getting a very small sliver of the next generation NCLEX universe? So here's the good news. Where did I get those 6 skeleton items? Well, I went through NCSBN's 5 sample case studies. And in 5 sample case studies, I've got 5 different recognized Q items. I've got 5 different analyzed Q items all the way through, right? I got 5 of everything, right? Well, point being, I chose one to make my recognized cues item skeleton. I actually had 5 to choose from, right? And for some of you that have access to other samples, not just the 5 on the NCSBN website, you've got even more. So really, while I used a particular item skeleton in this training, you can create or find your own item skeleton. You just take any, let's say, recognized cues, any recognized cues item that you like, that you think did a good job. You bring it over, you get rid of all of its scenario specific content, and you fill it in with your own. So the process that I modeled, we did use 6 very specific item skeletons, but the point is there was nothing magic about those. They were just the 6 I used. I could have used others. You can do this process with others as well. So take a deep breath. We got through the biggest part of the presentation, and now I just want to give you some advice or workarounds if you don't have super advanced software that helps you create things like pull down menu items, because the reality is most folks don't. When I worked in exams, briefly, I had it. Now that I don't work in exams and I work in outreach, I don't even have the software to create a working pull down menu item. So gosh, what do we do? So first thing to know, you're in good company. But what else? The main thing, I'm going to skip all the way down to this last bullet because I'll just illustrate the other things with real examples. I'm going to skip to the last bullet. I say the what is more important than the how. What do I mean by that? Let's look at clinical judgment. Let's look at recognized cues, right? What's recognized cues about? Here's all this information. What's most important right now? That is the what. What's most important right now? That is always going to be much more important than, oh, can somebody drag and drop stuff? Can somebody highlight stuff? That's the how, right? How does the item actually work, right? What we're measuring, recognized cues, matters more than what the item looks like. Let me show some examples. Let's take a look at highlighting. Not everybody can make a highlighting item. So on the top, I have what I call our high-tech version. It's a highlighting item. I think at my first workshop, we actually saw this very example. It's a highlighting item. You click on sentences and they turn yellow, like that. Okay, well, not a lot of tools out there create those things. I know there are some, but not a lot. Okay, so guess what though? Each clickable thing, each sentence, if you want, or each kind of, clickable important thing, you can actually take and just turn into, if you like, an answer choice in select all that apply. So I've turned this highlighting paragraph, high tech, into, right, that sentence was that, some second thing is that, right? So I've turned this highlighting item into a select all that apply. Now, I'm measuring the exact same thing, really, right? Which of these things are telling us the client is not progressing as expected? That's an evaluate outcomes item, by the way. Right? Which of these things? Here's the good news. I'm going to say in my demographic, right? I'm 53, my demographic, uh, it's easy to look and say, oh gosh, but would my student, when they see this top one that I've never been able to make myself, would they know what to do? Well, it turns out in the more typical student demographic, um, it's an easier adjustment for them than it might be for me. I know my son would have zero difficulty, but to give you something less anecdotal, we do something we call the special research section. It's how we tested out all the new item types going on to the exam, and none of the test takers, none of the grads who saw the special research section had any advanced knowledge, notice, training, directions for the item types other than literally the sentence you see here. Click to highlight the findings below that would indicate the client is not progressing as expected. They were able to comment as they tested on these, tell us if there's confusing stuff. We did usability studies, and what we found was that the item types weren't particularly mysterious at the level of the students or the grads. They figured it out. So what am I saying? You know, fantastic if you can create a highlighting item, but if you can't, don't panic at all. you've got my low-tech workaround, and your students who can ace this item on the bottom are going to do great with the item on the top. So uh, it's the what, right? It's the what, evaluate outcomes, clinical judgment, that we should care about more than what does the item look like, right? The cosmetics of the item, or what are the specific directions of how the right answer is indicated. I'm going to go now to a second one, pull down menu, because I know that's very difficult to do. This looks a little bit, in fact, this is the one that inspired my prioritize item that we used today. This is where I got it, right? Prioritize this thing first and then this thing next. Well, that's a little tricky to do with a single item, but here's the good news. High tech, well, look at low tech. We can just turn it into a pair of multiple choice items. Anytime there's a pull down menu, functionally, it's really just a multiple choice, right? Which one thing in this list is correct? So if an item happened to have two menus, well, we'd turn it into two multiple choice. And I suppose if an item had three menus, right, then we turn it into three multiple choice items. So again, if you've got students who could get this bottom thing right, the low tech right, they're going to do okay on the top one. They're going to do the same. They're going to do very well. So it's the what, the prioritization, the knowledge of prioritization that really matters more than what the item looks like. I'll give two more examples that have to do with matrix or grid items with two different setups. We've seen this today, anticipated or contraindicated. And you can probably already guess how you might attack this with a select all that apply. It'll be a little different, but I think close enough, at least the way I came up with. So here's our high tech, here's our low tech. Again, just like the highlighting, we just turn each of the things into a select all that apply answer choice. We didn't get to use the word contraindicated, unfortunately, right? So it's not identical, but again, if somebody knows the answer on the bottom, they're going to know the answer on the top. Final one, and then we're ready for our Q&A. Final one. It's a matrix again, but it looks a little bit different. You're going to get these slides, by the way, so don't try to write really fast. And we've got the recording, but I'll make sure through Randall that the slides are available as well. But let's take a look at this. It's a little different because instead of just choosing one thing, right, for each of the rows, like we did before, if you remember that, anticipated versus contraindicated, well, this time you could check off, pneumonia, UTI, influenza. You could go to town, right? You got the boxes mean you could do a lot more. Well, this was a challenge for me, low tech. I had to think about it a second, and then finally it came to me, right? So I'm sharing my findings with you. Essentially, a single item like this, you probably would need three items to cover the bases, but the point is you can do it. And if you have students who would do well with this low tech, they're going to be okay when they get to the real exam. They'll be okay when they see this. So let me sum up everything we've covered, and then we'll take some questions. So action model can help you create case studies just like the real exam that look just like the NCLEX, and more importantly, measure the same 6 clinical judgment skills. What else? I see in my work so many resources go to waste. Somebody might use a case study. Well, that's good. And then discard it. We already used it. Well, guess what? You could tweak the scenario a little bit, and maybe you keep the same questions, or maybe you tweak the questions, or you could say, "Ooh, I like that generate solutions item. I'm going to grab that and use it as an item skeleton for some other scenario," right? Um, these case studies, I'm just being honest with you, even for us at NCSBN, and we've been working on this for 11 years, the case studies take a long time to write if you're starting from scratch, if you're starting from a blank piece of paper. So I'm not saying never do that, but I am saying if you want it to go a little quicker and be easier, start from resources that are out there and adapt them, modify them. That's what we did in this exercise with the action model template. And then finally, like we just saw, if you don't have high-tech tools for pull-down menus and highlighting and all these things, you can still test the same clinical judgment skills. You just have to be a little clever or creative. Use the stuff I shared, or write to me and say, Jason, help, how do I do bow tie item? That kind of thing. And I'll write back to you. So, few things. I've mentioned newsletters. We've got a ton. I've mentioned that we've got these sample case studies out on our website. We do, but don't go to ncsbn.org like you might normally. Turn your head very sideways. These are at nextgennurses.org. That's us too. That's us too. Trusted authority on this kind of thing. If you ever wanted those case studies and maybe some bow tie and trend items sitting within a larger NCLEX looking exam that had multiple choice, select all that apply, fill in the blank calculation, kind of all the usual NCLEX stuff you know and love, but with the case studies and all these other things added, which is what's happening April 1st. Well, that's what this is. It's the same exact case studies, so don't get too excited. Oh, I'm going to get 3 more case studies. No, it's the same ones. But anyways, it just shows them sitting within a larger exam-like object. And somebody making fun of me with this slide, I have a cat video. I have the only cat video that hasn't gone viral on TikTok. But at any rate, if you want to know 6 minutes worth of stuff about computer adaptive testing, I've got your back. What else? Test plans are published. You're going to want those. Passing standards have been determined for NGN and the 3 years that follow, and they are the same as the last 3 years. No change to the passing standards. They did not go up, and most educators who follow passing standards have seen that as good news. So I won't disagree there, I suppose. I'd say just to allow time for questions, I'll skip that a little, but when you get the slides, you've got links to lots of stuff. And with that, I'm going to stop the slides and see if we have questions. And I think probably the chat is probably the best way since we've got quite a few of you. Okay, so any questions? And I think I will see the chat now. Okay, thank you from Deborah. Okay, you were ready to try writing. Good, Kathy. You know what though? I'm going to go off script. I don't have a script, but I'll go off proverbial script and say this. So pay attention to this. I shared hopefully some good information on how you can use our action model template to develop your own case study. But let's pretend we got 100 of you here. I'm going to tell you something even more valuable, right? In the closing minutes, even more valuable. Let's say there's 100 of you and you each go off and you write 2 case studies, which is going to take you a while, believe me, right? I kind of rushed you along, but it takes a while. 100 of you each go off and you write 2 case studies. Then you're each going to have 2 case studies for your troubles. All right. I encourage any audience I have to find a way to collaborate and share and network. Just imagine if you each wrote 2 case studies and now you've got 200. Can you imagine that? I mean, and maybe 10 of you each write 2 case studies, but somehow all 100 of you end up with 20. I don't know, right? Or maybe you get the 200 and you go through them and you don't like half of them. Well, I don't have a training for this. I really don't, right? So I don't know the how on this, but sometimes people take initiative and have some good ideas. If you all can find ways to network, share your resources, you're going to get a lot more out of it than just the handful of case studies that maybe you wrote based on my training. So please do give that some thought. I mentioned that Maryland Nursing Workforce Center. I think that was one of their aims, and they even have a way. I know you're not Maryland, but I think they even have a way. If you come up with a case study, they'll put it through their peer review and add it to their collection that all educators can access. So that's kind of an interesting concept. Okay, I'm seeing a lot of thank yous. So let me do this. I want to say thank you to all of you. This was a workshop where you all had to work as hard as me I got a free pass because I don't know any nursing, right? But y'all had to think hard on the nursing content. And as always, I want to thank Virginia Board of Nursing, and I want to thank Randall, who now twice has come to assist me in the chat. So, Randall, thank you very much. I'll turn it over to you in case you have any closing remarks.
Jason, again, thank you so much. And it was my pleasure to help you. You have helped us. And just again, a reminder, the recording as well as Jason's slide deck will be on the Virginia Board of Nursing website. If you go to the education page, directly under where the current education seminars are, there is a tab or a new heading that we have created called Archived Webinars. If you are on this call by telephone, please send to Miss Yates your telephone number and your name so that she can give you credit for attending this. It'll take us about a week to get the recording up, but it'll be there. And as Jason said, please share it far and wide. And That's all I've got for today.
All right. Well, Randall, I did see a question that says, when's the next one? I should say I've told Virginia everything I know about the NGN at this point. I don't even think I know anything else. But Randall, you're always welcome to reach out if there's anything that you think I can help with. I'm always happy to at least do my best, even if it's inventing an entirely new training that I haven't done before. So let's keep in touch. I've got your number, you've got mine, and maybe we will have part three.
All right. I appreciate
Okay.
it. All right, guys. Thank you all so much. Have a great day.